Hi everyone, and welcome to Nursing Notes and Knowledge and today's quick and informative lesson on hypokalemia. In today's video, we're diving into a common and important electrolyte imbalance that every nurse and healthcare provider must recognize, as it can be a life-threatening one. Whether you're prepping for the NCLEX exam or caring for patients in the clinical setting, this is a topic that you won't want to miss. So there are several textbooks that dive into this topic at great length. My intention for this video is to provide a broad overview of hypokalemia, serving as a supplement tool for studying and aid for your exams. I've listed my reference text below in the description box. Without further ado, let's get started. What is hypokalemia? Hypokalemia means low potassium levels in the blood, specifically less than 3.5 milliequivalents per liter. In the next few slides, I'm going to address etiology, clinical manifestations, clinical management, interventions, nurse diagnoses, as well as study tips and tricks. As far as a general overview, potassium normal serum value range is 3.5 to 5.3 milliequivalents per liter, and anything less than 3.5 is considered a potassium deficit. The normal serum potassium range is a narrow one, therefore levels outside the range can be life-threatening. A serum potassium less than 2.5 can cause cardiac arrest. In terms of distribution, 97% of potassium is located within the cells, intracellular, and most abundant in the GI tract. As far as function, potassium is crucial for nerve function, muscle contraction of the skeletal, smooth, and cardiac muscles, as well as maintaining a regular heart rhythm. Potassium also assists with acid-base balance, and is important to note that hypokalemia is associated with alkalosis, and potassium does assist with cellular metabolism. In terms of body involvement, etiology and pathophysiology, causes include several. First, renal influence, excess potassium excretion in the urine, or diuresis, GI loss due to emesis, diarrhea, or malabsorption, high-dose steroid use, inadequate potassium intake, trauma, tissue injury, burns, or surgery, and lastly, hormonal influence, insulin and aldosterone. Now, some of the more common reasons for hypokalemia include loss through body fluids. For example, diuretics, vomiting and diarrhea, nasogastric suctioning, laxative abuse, and excessive sweating. With diuretics, particularly loop and thiazide diuretics, in terms of intercellular shifts, conditions like alkalosis or insulin administration can push potassium into cells, lowering blood levels. Additional causes may include inadequate intake, not getting enough within the diet, malnutrition, eating disorders, alcoholism, and just overall low potassium diets. So, physical signs and symptoms and manifestations of hypokalemia. These include fatigue, malaise, confusion, muscle weakness, cramps, mostly noted in the legs, anorexia, nausea and vomiting, decreased GI motility, decreased peristalsis, constipation, paresthesia, numbness and tingling, and diminished tendon reflexes. And most importantly, cardiac considerations. On an EKG, you may see EKG changes, PVCs, flattened or inverted T waves, ST segment depression. If changes are noted on the EKG, it's time to act and intervene quickly. As a nurse, you must watch for these symptoms, especially in high-risk patients, like those on diuretics or patients with GI loss. An additional consideration is sensitivity to drug digitalis. With low serum potassium increases the risk of dig toxicity. This is because digitalis drugs work by inhibiting the sodium-potassium ATP adipase pump in the heart's cells. So a state of hypokalemia basically enhances this inhibitory effect, making the heart more sensitive to digitalis. So in terms of assessment, as a bedside nurse, you will always want to assess the following and to be included within your head-to-toe assessment. First, recent medication use, especially diuretics or insulin. Assess for GI losses, including vomiting, diarrhea, nasogastric suctioning. Cardiac monitoring. Assess EKG changes and report any abnormalities immediately. You want to monitor serum potassium levels and other pertinent electrolytes. Assess muscle strength and signs of fatigue. Assess dietary habits. Patient education is key. You want to encourage potassium balanced diet. Identify and manage underlying cause or causes, whether it's stopping a medication and or treating any GI losses. Other treatments and interventions depend on the severity and cause of the hypokalemic state. Again, monitor patient eyes and nose, administer potassium supplements, and encourage a potassium-rich diet and foods. Hold or adjust diuretics, correct magnesium deficiency if present, and educate patients on diet and medication compliance. Further clinical management of hypokalemia. Successful management of this imbalance requires immediate intervention. For mild deficits, oral replacement is frequently ordered or as a preventative measure. IV potassium chloride is given for more moderate to severe deficits, and it should be noted that IV potassium should never be given IV bolus or IV push, as cardiac arrest may result. Confirm the cause for the potassium imbalance and that it has been corrected. Evaluate the effect of the correction of the imbalance and make necessary adjustments if required. So potential nursing diagnoses and patient management of hypokalemia. Remember, you're always going to obtain a health history. You're going to assess for signs and symptoms of hypokalemia, check your EKG for changes, particularly changes that denote hypokalemia, and always check your serum potassium levels. Normal range is 3.5 to 5.3 milliequivalents per liter. In terms of diagnoses, I have listed 3. Number 1, imbalanced nutrition, less than body requirements, related to insufficient food intake rich in potassium, or related to potassium losses, secondary to emesis or GI suctioning. Number 2, risk for decreased cardiac output, related to dysrhythmia, secondary to hypokalemia. And number 3, impaired urinary elimination, related to renal dysfunction and or cardiac insufficiency. Next, I have some memory tips for exams and practice. For hypokalemia, specifically, think slow and low. Low potassium equals slow and weak muscles. Cardiac, weak heart. Bradycardia, irregular rhythm. Weak GI equals constipation. Respiratory, shallow breathing. Other tips include the use of mnemonic acronyms or rhymes, writing out notes more than once, repetition aids in memorization, engage with the material by teaching it or discussing it in study groups. Use of written flashcards is always helpful. Reviewing material at increasing intervals strengthens retention. And lastly, a healthy lifestyle. Proper sleep, hydration, and stress management boosts cognitive function and memory. Lastly, some final closing thoughts. Hypokalemia can be a silent threat. It may start with fatigue or a cramp, but it can end with a deadly arrhythmia if left unchecked. As nurses, your ability to spot the signs early, respond effectively, and educate your patients is life-saving. So if you found this video helpful, give it a thumbs up and a subscribe. Now that you have more understanding of hypokalemia, have you ever cared for a patient with low potassium What signs did you notice first? Drop your experience in the comments below, as your insight might help another nursing student out there. Thanks again for watching, and we'll see you on the next one.